Good morning and welcome to this morning's Frontiers Grand Rounds this morning. It's my pleasure and I'm so excited to be able to introduce Dr. Amelie Ramirez, who is Chair and Professor of Population Health Sciences and Director of the Institute for Health Promotions Research at the University of Texas Health at San Antonio. Dr. Ramirez is an internationally recognized cancer and chronic disease health disparities and health promotion researcher. She's chair and professor of population health at UT Health San Antonio, where she is the founding director of the Institute for Health Promotion Research and the associate director of cancer outreach and engagement at the Mays Cancer Center at UT Health San Antonio. Over the past 30 years, Dr. Ramirez has directed over 100 research programs that are focused on health and organizational communication to reduce chronic disease and cancer health disparities affecting Latinos and other minority and underserved populations, including cancer risk factors, clinical trial recruitment, patient navigation, tobacco prevention, obesity prevention, and many, many more risk factors. Dr. Ramirez has authored many peer-reviewed articles, is an editorial board member on several prestigious journals, and is frequently invited to speak at national and international scientific meetings. She's been widely recognized for her work to improve health and advance Latinos in medicine, public health, and behavioral sciences across the United States. And she's on the San Antonio Mayor's Fitness Council, is board president of Academy of Medicine, Engineering, and Science of Texas. Dr. Ramirez is a native of Laredo, Texas, and she received her MPH and DrPH degrees at the University of Texas Health Science Center. And actually, Dr. Ramirez and I have crossed many paths. As I lived in Texas, we were both students at the University of Texas School of Public Health, and we were both on the Susan Komen advisory board, scientific advisory board. We were both Komen scholars together. So we have really crossed many paths. She's also received numerous awards for her work. She received the 2018 Icons in Healthcare Award for her recognition and dedication of service and leadership in healthcare. And this award recognizes individuals that have made significant contribution in improving the healthcare in the San Antonio community. She was also the 2018 Top National Latino Leaders for 2018, honored during the National Diversity Council's Latino Leadership Conference. She was, as I mentioned already, she was a Komen Scholar. She was also in their Scientific Advisory Board, and she's always called on by Susan Komen to do many things. In fact, we were working together on a call recently for the Share for Cure study that's going to be launched soon. And she's had so many awards that she's been recognized for her work over the years. So it gives me great pleasure to welcome her to today. And I wish that she was here in person, because I know she would really love being here in California. And we were just talking about how long we need to continue working, because there's so much work to do in this area, and especially so that our children, our grandchildren will have a better world. So I'd like to welcome Dr. Ramirez today.
Thank you so much, Dr. Bondi. I really appreciate it. And it is truly a pleasure. I almost envy all of you for living in such a progressive state like California that has so many opportunities for doing some amazing work. I just want to thank you for this invitation. Thank you. So I'll just go ahead and again, Dr. Bondi and I go back a number of years, and just have really enjoyed working together, and to see that we have such similar paths. But again, it's a pleasure to be here, to be part of your frontiers. So thank you so much. My presentation today, and Maria is going to help me move my slides forward, because we've been having a flaky internet service here, but is to really talk about Latinos and cancer, and how can we create a better survivorship journey for them. On the next slide, I'd like to just share with you a little bit about who we are. Dr. Bondi mentioned the Institute for Health Promotion Research. I had the pleasure of working with Dr. Larry Green and many other individuals who've contributed, Alfred McAllister and others who've contributed so much to the field of health promotion research. And so when I was recruited to San Antonio after leaving Baylor College of Medicine, they asked me, well, what do you want to do? And said, we'd like you to set up a center for health disparities. And I said, no, our Latino community has already faced so many disparities that I really wanted to talk about something that would be more uplifting. How can we help them improve their health or promote their health? And so I was able to name the Institute as the founding director, as the Institute for Health Promotion Research. And we're a small and mighty team. I also am the department chair for the Department of Population Health Sciences, which has another large cadre of faculty. But this is my core faculty here at the Institute. And our mission is to really focus on the causes and solutions of the unequal impact of cancer and other chronic diseases that are impacting our residents here in South Texas and also the nation. And so we're here to improve everyone's health as much as possible and to share our models on a national basis. On the next slide, this is what my presentation will entail, talking a little bit about what we know about Latinos and cancer, and then followed by cancer survivorship data, and then really focusing on 3 different studies that we have done that are focusing on Latino cancer survivors, and a little bit of what our future holds. So on the next slide, here we find that Latinos right now represent over 18.5% of the US population. What is less known is that Latinos actually are now the leading minority majority in the United States. And I don't think many people hear that. And so I can't start a presentation without bringing this fact up, right now by 2060, they will be representing 27.5% of the US population, or numbering over 111 million in 2060. So as you can see, this high projection, and Hispanics accounted for more than half of the total US population growth since 2010. The next slide. And we are very diverse. We're a very heterogeneous population. And to this date, I'm sometimes representing all of us when I'm asked to sit on different national committees. And I'm going like, no, we now need to be more representative of what are the issues that are impacting our Latino population. Yes, Mexican Americans make up the majority of our population here in the United States, followed by Puerto Ricans, followed by Cuban. But again, we have a number of different Latino ethnicities that are increasing here, and that we need to be more sensitive in reaching, right? We maybe have a common language, but there's still diversity in how we use our language or how we refer to different foods. Everybody has their kind of colloquialisms and referring to different things. And so that if we really want to be sensitive in how we reach our community and we need to recognize who is within our community. So this is just some of the data that I'd like to share with you. But the next slide, but what we hear the most though, and I think COVID really brought this to the forefront, is all the health inequities and the social determinants of health that have impacted this population, right? They were the front line of services. They provided help in all different areas. They were the ones that kept the grocery stores open, were the cleaning up in the hospitals and all of these. But again, our population represents a very wide spectrum and of education and economic status. And again, this varies by the different types of ethnicities and of the different Latino populations. But this slide really focuses on all the social determinants that are impacting our community. Poverty, for example, and income inequities. 1 in 3 US Latino families live in poverty. We have high, or high rates of uninsurance in our population. So therefore, the lack of access to healthcare is critical. They have less stable housing. Their access to safe places to play are very limited for our children. There are food deserts in their communities. And then also the inequitable access of early education. And we all know the importance of having a good education. 42% of our children live in what we call childcare deserts. Families that have to go to work don't really have convenient places and places that are of high profile to place their children in for care while they go to work. And all of this, and then the continuous exposure of racism and discrimination. And then again, through COVID, the amount and the volume of misinformation that was targeted to our communities. So again, these issues are so important when we consider and develop in research projects. So really get to know your communities and what are some of the things that they're facing. We need more tailored and culturally appropriate programs to reach our community. On the next slide, we'll see that cancer is expected to rise to 142% in our population by 2030. That's not very far, right? We're already in 2022, in 8 years, this expansion of cancer. And Latinos might be less likely in terms of incidence and prevalence of certain types of cancers, such as lung and colorectal, but they show poorer outcomes because they're not being diagnosed early. And at the same time, they have higher rates of cancers that are associated with infectious agents such as liver, stomach, and cervical cancer. And on the next slide, this is kind of a dramatic slide, but cancer now is the leading cause of death for Latinos, not cardiovascular disease, but cancer. And in 2021, cancer was expected to take the lives of over 45,000 Latinos. This would fill 13 Titanics. That's 3,300 in each of these boats. So that would reflect the crews and passengers of the boat are dying. And what are we doing to mitigate these skyrocketing numbers in terms of cancer disparities? On the next slide, I'd like to share a little bit of data on cancer survivorship and why this is now a population that we need to be focusing on. And then I'll describe a few of the other studies that we're involved in that also target cancer or that were designed to reach out to our cancer survivors. First of all, many of you may know the definition of a cancer survivor, but a cancer survivor is anyone living with a history of cancer from the moment of diagnosis through the remainder of their life. And this is a definition that's being used by the National Cancer Survivors Foundation. And what happens is that survivorship is considered really important to look at because it involves so many different areas. It encompasses physical, psychosocial, economic sequelae to cancer diagnosis or economic sequelae due to its treatment. It really impacts our population that are that have cancer, but there's a number of issues that they have to deal with. On the next slide, the good news story is that we're making such amazing advances in basic research and treatment modalities that this has resulted in a 45% increase in survival rates in the United States since 1979. And it's expected to surpass 22 million by 2030. So that's the good news. And this graph chart here shows, the different age groups that are impacted by cancer. For example, 16.9 million in 2019 were representing approximately 5% of the US population, and 64% were aged greater than 65, 67% lived greater than 5 years past their initial diagnosis, and 18% were living past 20 years, depending on their stage and the initial site of their diagnosis. So the 5-year survival rates for all cancers combined has increased substantially since the early 60s, and from 39 to 68%, particularly among our non-Hispanic population, and from 27% to 63% among our African American community. But not as much data is available on Latinos. And survival rates vary by cancer type and stage of diagnosis. The next slide, this is the different types of cancers. Of the 16.9 million survivors in 2019, the majority of them were female breast cancer survivors, and more than 3.8 million prostate cancer survivors were males. And the National Cancer Institute estimates that cancer-related direct medical costs in the US were $183 billion in 2015, and that's expected to increase to $246 billion by 2030, or a 34% increase based on population. And so these projections truly underestimate the true costs of prescription medicines, with the list price for many now over $100,000 a month annually for some of our patients. On the next slide, as I mentioned earlier, our cancer survivors and health-related quality of life really are affected by so many different things. For example, 1 in 4 of our cancer survivors report less physical health-related quality of life, and 1 in 10 express less emotional health-related quality of life. And as you can see here, in terms of the treatment and disease sequelae, a number of things are impacted, all the way from pain and fatigue to occupational problems and financial toxicity and everything else in between. And Melissa and I have worked on a lot of projects looking at young and adolescent children and who were diagnosed in childhood, and now we're seeing a lot of the cardiotoxicity long-term effects that some of these children are having. So again, here you can see the important problems here. This is Cameron Matthias. He's 50. He had renal cell carcinoma. And Tiara Kashap, she's a writer, director, and she's a breast cancer survivor. So these are many of the things that we need to learn more about how to improve their lives. And on the next slide, our cancer survivors worry about a lot of things. They worry about how they will cope with the cancer and all the things that happen. They have fears about the future, what the future will be like. One individual wants to know, am I going to die? What is happening to my body? Many no longer feel safe and may feel afraid, and exposed and weak and vulnerable. And at the external level, concerns about what's going to happen to their families, their relationships, their jobs, their insurance coverage, and finances. So this number one fear is also recurrence, because again, they're at greater risk due to a number of the treatments, a number of the other risk factors that they may have. And nearly half of all cancers are caused by unhealthy lifestyle choices, as we all know, such as smoking, poor diet, sun exposure, or alcohol abuse. And so these are some things that, again, we need to help them to bring under control so that they can have a healthier lifestyle. And the next slide, but we also have less information about the impact of stress, right, that this has on a cancer survivor. So cancer diagnosis and treatment induce both biological and psychological stressors that may promote premature aging of the immune system in our cancer survivors and increase the long-term effects that it might have on their quality of life. So this is where we're hearing a lot about the importance of designing some holistic type programs. Now I'd like to quickly move into what do we know about Latinos and cancer survivors. On the next slide, what we see here is that about 4 million Latinos are cancer survivors, but our cancer survivors are more likely to be poorer, have low education levels, have no health insurance, and no resources for primary care compared to non-Hispanic whites. And the uninsured or underinsured individuals are more likely to be diagnosed with late-stage cancers and have worse treatment outcomes and survival. On the next slide, we show that some of the lower cancer survival rates after accounting for differences in age are really because of the stage distribution. Even with proper access to healthcare, they experience disparate treatment options, including low inclusions in clinical trials or other types of experimental therapies. And they experience poor health-related quality of life as survivors. Now, on the next slide, I'd like to just go through the outline, and now I'd like to transition to a new study that we were just awarded a year ago called Avanzando Caminos. The next slide shows, this is our Avanzando Caminos, or Leading Pathways for the Hispanic Latino Cancer Survivorship Study. Is a joint study with Dr. Frank Peñedo from the Sylvester Cancer Center and myself, and Dr. Peñedo and I have worked together for over 20 years. I had some of the first studies that were funded by NCI called Redes en Acción and Leadership Initiatives on Cancer for Latinos. And together we really kind of established that pathway of working together, and our collective experiences led to the award of this particular study. So I'm really excited to be working. It's really the first Latino cancer survivorship study to be funded by NCI. On the next slide shows you our conceptual model for this particular study. It's a 6-year study, but our first 2 years are under the UG3, so that we have to prove that we can actually accrue our participants and gather the data that we need. Our goal is to recruit over 3,000 Latinos, about 50% Mexican American, and the other 50% of the diverse Latino groups, about 50% female. Most of them will be coming from our own electronic medical records at our respective cancer centers, but then we'll also be wanting data from our cancer registries, our respective cancer registries. And the Texas registry just became part of the SEER database, but they're a little bit slower in accruing the data. So I'm a little concerned there, but I hope we'll gather some good data. And then part of the more rural population will probably come from South Texas. We're focusing on 8 specific tumors. And again, our rates are reflective of the cancers that we see in both our communities. As you can see here, this conceptual model is a pretty dynamic model, but we'll be collecting information on the social cultural domain, on the life and behavioral styles, psychosocial issues, looking at stress and adversity domains, and also biological impacts, and how all of this impacts our study outcomes related to symptom burden, quality of life, and disease activity. On the next slide, these are our major study aims. Is that to establish this survivorship cohort, to examine the multiple determinants of symptom burden and health-related of life and disease activity, look at what are some of those psychosocial mediators, and to evaluate some of the biological mechanisms. We're really interested in looking at the different backgrounds that are represented in our different Latino populations, because I think we're going to see a lot of variation there, and then also explore other potential moderators. And on the next slide is a little bit more describing our inclusion-exclusion criteria. We are recruiting individuals who are over the age of 18, who have completed their primary cancer treatment for a primary tumor with no adjuvant treatment. Excuse me. And the primary cancer diagnosis, we need to confirm on the electronic medical records or the cancer registry. And these are the cancers that we'll be looking at for breast, colorectal, kidney, renal, liver, and lung, prostate, stomach, and uterine cancers. Our population should have at least a 6th grade reading level or higher, that their willingness to attend all our study visits, and that they have no severe cognitive impairment and no psychiatric treatments within the last 6 months or participation in any behavioral studies, and no metastatic disease, and no participation in behavioral trials. So on the next slide, I'm trying to keep track of time here. What we found is that this will be our assessment. We'll be recruiting our participants. Since they're coming from our cancer centers, we'll be reviewing the EMR abstraction. We need to consent them and get them in. And then the actual study right now is taking about 4 hours in terms of data collection, and we do a blood draw. And then we'll have the 6-month visit will only be a reduced assessment, and then we'll be doing yearly visits with blood draws done every other year. Next slide. This is again our proposed recruitment. Right now, we've just been a little less than a year in the field. We had to get all the study protocols approved and up and running, and we've recruited about a little under 100 participants. Our goal was to recruit 240 over a 2-year period of time. So we have been in communications with NCI, but this is the distribution of the different types of cancers that we're hoping to recruit. Next slide. And this just shows, again, the regional areas of where we're recruiting from. As you can see, Miami and them would be more of an urban communities, and South Texas, we're in the green here. We have quite a few rural communities that we'll be drawing from. Next slide. These are just some of the promotional materials that we have developed for our studies to educate our community here, so that when we do make that cold call, that maybe they've heard about it and obviously willing to participate. Next slide. And in terms of our findings, we hope that we'll be able to provide novel and critically needed information to inform and guide secondary and tertiary prevention type programs, to identify differential impacts of the different determinants that are impacting our diverse Hispanic and Latino population, and to identify any possible modifiable psychosocial or behavioral and biological mechanisms that could help improve the management of our cancer survivors. In the terms of who we're already been recruiting, one of the sad things that we are learning is that we've had to exclude a number of participants because of their metastatic site. And so we are considering maybe including metastatic disease. And so we're discussing with NCI if it would be okay to open that criteria, only because people are living longer with metastatic disease, and maybe we can find some unique information that would be helpful to them. Next slide. So the next slide is really to help discuss just very quickly a hormonal treatment helper app that we have developed. So next slide. And this is a study funded through Komen to see how we could impact endocrine hormonal therapy. We know that a lot of individuals are benefit from this therapy, but about 80% are not taking their doses as they should, and about 30% of women who are prescribed do not take their medication as prescribed. I'm sorry, about 80% of the population is eligible to take this medication, and then of those who do take it, 33% of women are prescribed to not take their medication as they should, and are increased risk for recurrence, right, and increased mortality. So minority patients, again, are less likely to adhere to these medication regimens, and barriers are multifaceted. So we really wanted to learn, what could we do to help improve that? On the next slide, what you see here is that we developed this app plus having the assistance of a patient navigator. So we developed a pilot test, a bilingual program, and an interactive mobile app in a combination with patient navigation to promote and improve adherence to hormonal therapy among our breast cancer patients. It was a two-arm randomized control study with 120 breast cancer patients who are currently receiving treatment at our cancer center. The intervention is aimed to empower self-monitoring and management by the patient. It will also facilitate patient education, early identification, and reporting any side effects that they may be having to their provider so that they can be given specific advice on how to deal with some of those and give them, be able to provide them with timely feedback, and then also to facilitate direct interaction between the patient and the oncology team if needed. And the next slide lists some of our major outcome variables that we were looking at, as well as some of the secondary variables as well. This study is just nearing completion, but we're still doing some follow-up. On the next slide. And this is our study flow. As you can see here, in the red is where we actually had specific tasks assigned to our patient navigator to assist the patient. And on the next slide, one of the things that we all know, right? We really wanted it to be a useful tool, and we really wanted a lot of community impact. So to assist barriers and facilitators to hormonal therapy adherence and to the key symptoms and develop useful app content, we conducted 8 focus groups with 48 breast cancer patients. 4 were in the formative stage and 4 were in the pre-testing stage. And then we conducted 8 semi-structured interviews with our oncologists, nurses, and patient navigators and advocate to make sure that we were incorporating what they thought patients should know, but also from a patient perspective. So this qualitative data really informed the initial design and development of the app and its mock-ups that we were able to assess through our focus groups. And then based on that, we developed the protocol for beta testing. One of the main things that came up was obviously we want it to be easy to use, we want it to be colorful, and so forth. In terms of the next slide, some of the things that we learned or recommendations that came from these formative focus groups was that to please explain the potential side effects and how they might manage them. We included testimonials from real patients and how they dealt with some of these symptoms, and that the tool should allow the user to report any side effects and have access and to provide them with kind of a weekly summary report in the form of a graph to see how well they were dealing with some of the symptoms. And we also incorporated inspirational quotes and messages to keep them moving forward. And it also provided reminders or check-in messages about the medication. Next slide. These are just some samples again of our recruitment materials and how to utilize the app that was given to the patients once they were identified. The next slide is just kind of our anticipatory results are that hopefully with this app, that we've reduced healthcare costs and improvements in breast cancer outcomes by reducing recurrence, right? And improving the quality of life for our breast cancer patients. And also just, helping them deal with any side effects that they may be having. We're hoping that this program will provide evidence-based information that can help us scale it up now into a true R01 study. Our next slide is on improving diet. On the next slide, we know that breast cancer is a leading site of female cancer cases, and it's the top cause of cancer death for Latinas. And we wanted to see how we could improve both treatment and detection, since now we have a large number of cancer survivors, but obesity in our breast cancer survivors is associated with high recurrence and mortality. So we felt we needed to design something that could help them bring that under control and also to deal with inflammatory issues. On the next slide, we had reviewed several studies that had demonstrated the relationship between pro-inflammatory diet and the increased risk of breast cancer, and that an anti-inflammatory diet post-breast cancer diagnosis was associated with reduced risk for cardiovascular disease, and that thus dietary patterns may play an essential role in modifying inflammation and reducing the risk of comorbidities and recurrence for our breast cancer survivors. So that was the rationale of our study. We worked with some of the next slides. We worked with some of our basic scientists as well. And one of the things that we were looking at were circulating adipose stromal cells, because we know that these proliferate in obesity and are linked to higher recurrence and decreased survival in prostate and colorectal cancers, but we didn't know about its impact on breast cancers. So we previously showed that higher levels of ACS among obese breast cancer survivors that were involved in a physical activity intervention, but we had not done anything with